Hello, my name is Hope Frost, and on behalf of SBK Healthcare, I'm delighted to welcome you to this video on SACT, drug home delivery and self-administration. We do hope that you enjoy it. Please share your thoughts in the comment section and make sure you subscribe to our YouTube channel so that you don't miss any new content that we upload. It's now my pleasure to introduce your webinar leaders, Abigail Orchard and Andy Harris.
Thank you. Well, thank you for inviting us to do this presentation today. My name is Abigail Orchard and I am lead cancer nurse and nurse practitioner down at Dorset County Hospital in Dorset. And my colleague Andy Harris is with me, who is a senior pharmacist here, who leads our subsidiary pharmacy. We're going to be talking about two subjects this afternoon. One is administration of subsidiary, and the other topic is home delivery of oral SACT and supported medications. So I'm going to kick off with the self-administration of denosumab, and then I'll hand over to Andy, who will do the home delivery service. There's been quite a lot, as you will all be aware, both in presentations and in certainly healthcare press around changes of service delivery models, particularly since COVID. And you may already have seen some information about both these topics. So some of it may be repetitive, but hopefully you will learn from some of our own experiences that you can take to your own healthcare settings. So the aims of the sessions really are to just give you a bit of background to the changes in practice that we have instigated here in Dorset. I'm going to describe the self-administration of denosumab, including the patient pathway and some benefits and challenges that we found. And Andy's going to do the same regarding the home delivery service of oral SACT. And there's going to be some time at the end for questions and answers. So we would value you think about those as you go. And as Daisy and Hope have said, please put those in the question and answer box as you go, and then we can collate those and answer those questions at the end of the sessions. So denosumab, we're all familiar with denosumab. We all use it for many of our patients, both hematological and solid tumours. And for what's often a quick 5-minute injection, patients, end up generally coming to hospital for sometimes an hour or more. And obviously with COVID, we wanted to make some changes to this pathway. And we felt that denosumab was a really good one to start with, in terms of it not really being a cytotoxic agent, but certainly being an important supportive agent that we use in cancer care. So I'm not going to go too much into denosumab because I'm sure those that are on the call will know about denosumab. We actually started this initiative before COVID pandemic. So last year we recruited a metastatic breast cancer nurse, and the new role allowed us to explore new ways of working. Now, many of Charlotte's patients on her caseload were on denosumab, and they were all coming into the hospital for their monthly injection. So with her new role, she had a bit of headspace and thought about new ways of delivering this treatment. We also knew that many of our patients already self-administered other medications, such as enoxaparin, for example, heparin, and also the filgrastim injections and EPO injections as well. So many of them were already experienced in self-administration, and obviously patients with comorbidities such as diabetes are also used to self-administering. So we thought about utilising that knowledge and patient experience, and where else could we use it. So with just a bit of background really, with our metastatic breast cancer nurse, as with most hospitals, we really struggle with space. And when we recruited Charlotte to the post, we were really struggling for an office space. So that factor, together with the fact that ladies with metastatic breast cancer are often quite poorly, however, they live for many years, and we want those patients to have the best quality of life. So we decided that a good way to be working would to allow that post, although secondary care based, to do domiciliary visits. So it started that Charlotte was able to go out to patients, or does go out to patients on a regular basis, to their homes. And this then, through discussion with patients, it materialised that actually it'd be really useful to be able to, for patients to be able to self-administer, and allowing them to self-administer their own things such as denosumab. Obviously, it has many benefits, which we'll talk about. So we already had a bit of a dipped our toe in the water with regard to self-administration of denosumab. And then with COVID, clearly things had to change. And we looked at all sorts of ways of trying to not only free up space in our chemotherapy unit, but more importantly, to try and keep patients out of hospital. And so that was a real driver behind this change. Many of our patients, as you will all be aware, were highly anxious and had all been told to shield. And that shielding really, was understandably taken very seriously, and so it should have been. And, the last place they wanted to come, if at all possible, was hospital. So what are the benefits and challenges to an initiative like this? Well, they're fairly obvious, but just to run through the benefits, clearly having self-administration of denosumab or any other medication does generally reduce hospital visits, and it reduces the patient's exposure to other people. Now, that might be healthcare professionals, but also other patients. And whilst we all do our very best to ensure spacing is appropriate between patients and staff, and we all wear appropriate PPE, there is still that concern from patients that, we're close to them. And so trying to keep them out of hospital is definitely better. Obviously, anything we can keep out of hospital, and particularly where it involves self-administration, means that we increase the capacity in our chemotherapy units. And we're all struggling for space in our units, and anything we can try and send elsewhere for delivery is got to be a positive. So we're not only increasing chair space or chair capacity, but we're also reducing the impact on the chemotherapy nurses. I think thirdly, important that this sort of initiative empowers patients. So it empowers them to address their own health needs and to be in charge of their own treatment or aspects of their treatment. And that, I think, is really important, particularly for a group of women who in many respects have a lot of things taken away from their control. They've got a disease that is progressive, but we want to try and improve their quality of life for as long as possible and increase their independence. Obviously, it has an impact on practical concerns, including things like travelling time. Patients in Dorset's quite a big county, many of you will know, and the travelling time that they use to get here can be quite significant. They have problems with parking, as with most town or city hospitals. Parking is a problem, and also it's patients spend a lot of time getting to and from hospital for appointments, so reducing these practical issues is important. I think it probably goes without saying that for many patients, doing something like self-administration and staying out of hospital improves their quality of life generally. It's a bit of a generalised statement, but I think one would agree with that. And the final benefit really that we found was that actually there is a cost saving. So by delivering things to the patient's home, which Andy will talk more about shortly, but including things like denosumab, we do have VAT savings, which we can then plough back into the organisation. But I won't go into any more about that at the moment. I'll let Andy discuss that later. Obviously, with any new initiative, there's always challenges, and we try to address those challenges as we went along and before, from listening to others who'd also started this initiative off. The challenges are that, of course, we're all used to seeing patients face to face and eyeballing them and making assessments on what we can see in front of us. And because patients aren't now coming to hospital so much, we don't get the opportunity to see patients and actually visibly assess them. Much of our assessments now are done over the telephone or via video conference calls, and we will now end up that we sometimes don't see patients for many months face to face. There's also there's an idea that actually patients, we know, gain a lot of support from their peers. So when they come into hospital and sit in the chemotherapy unit with other patients who have cancer, they gain support and support from those interactions. And obviously less hospital visits does mean less peer support. And of course, there are some patients that, despite support and education, struggle and lack confidence in the injection procedure. So perhaps for some patients, it doesn't end up as a positive experience, and they end up referring back to hospital for their appointments. So things to consider when we're looking at subcut denosumab. Obviously, patient suitability is important, and I'm going to go through each of these in a bit more detail, and identification of patients who would be suitable. Patient education and information is vital to any initiative like this. You know, how we educate our patients and ensure that they are confident in the procedure is going to be important. A standing operating procedure is important to ensure that it supports and governs our practice. The patient pathway, there needs to be a fairly robust patient pathway that describes each point of the pathway, so that we ensure that patients don't slip through the net and nothing goes without going through a fairly robust and a tight schedule, if you like. Pre-treatment assessment is important. Just because patients aren't coming to hospital, we still need to be able to assess them in an efficient and a safe manner. Obviously, dispensing and delivery of the medications is an important thing to consider. And then health and safety and governance issues are also vital. So we're going to go through those in a little bit more detail now. So patient suitability for self-administration. Well, obviously lots of our patients, you know, are already on denosumab, and some have been on it now for several years, so are used to the injections. So we approach those patients first, and they're fairly easy to identify by going through our diary. And as and when those patients come to the unit, our chemotherapy nurse specialist or the metastatic breast cancer nurse or even the chemo nurses can talk to the patients about the initiative and just get them on board as to whether they think this is something they'd like to try. It's certainly not mandatory. It's something that we offer as an option for them, but we obviously actively encourage that. As part of that, we would explain the self-administration program and what it would look like to reassure patients that they won't be disadvantaged at all by doing the self-administration at home. Obviously, you know, before we move further, we needed to get any patient's consent or general agreement in principle. And once a patient had showed some interest and was keen to pursue the idea, then we considered other principles, such as what support they had at home. And we also thought, you know, do patients have any factors that might cause problems, such as reduced dexterity, sight impairment, and obviously fears and anxieties, which some patients understandably have about this sort of thing. But we found that, you know, like we do with other injections, such as filgrastim, many patients are fearful to start with, but once you have careful education and training and support them through supervised practice, many of those fears are allayed and they usually go on to be successful at self-administration. So with our knowledge of and experience in those areas, we move forward with this initiative. So patient education is obviously key, as I've mentioned, and that education is generally done, well, it's always done face-to-face. So we will use our SACT nurse specialist to spend time with a patient face-to-face, generally in hospital, but also sometimes at home. So we have the flexibility of allowing our SACT CNS to go on home visits and educate the patient in their own home, which I think has a great advantage in that the patient is in their own surrounding where they're going to be doing their self-administration. So by doing some supervised practice and education at home, that seems to be a good way forward. We give all our patients a patient pack, which has got lots of information in and includes access to leaflets, step-by-step guides, information about dental issues, and we all know that there are some significant side effects with denosumab, which we need to talk to patients about in advance of treatment. There's also information that we can signpost patients to around videos and online films which are produced by Amgen, which are very useful. So we utilise the information and we put it all in a pack and give it to our patients. Within that pack, we also have a record of our education, so that we can sign off to say the education's been delivered, and also that the patient's undergone supervised practice and when that was and any problems that arose in those instances. We talk about side effects from treatment as part of the education and what patients should look out for and what we'd want them to report to us. And then we go through the observation of the injection procedure, and we first of all show the patient how we would draw up the medication. We talk about the equipment that we're going to use. We talk about the importance of hand hygiene, both before and after the procedure. And we talk about waste disposal and documentation in terms of ensuring that the procedure's been documented and where to report any problems. And what we've been doing as part of our process is we've been watching patients on 2 occasions. So they may watch us on one of the occasions, or in the patients that have been having it for many years, they've seen the injection done many times. But in any situation, we would observe patients doing 2 injections to themselves. I mentioned about reporting side effects or any problems, and we make sure all our patients, including those on denosumab, have access to our 24-hour hotline and how to use that. This is something that comes actually with that Amgen have produced, but we found it very useful in that it goes in our patient pack, and it almost provides it's almost goes on a tray. So we advise patients to to use a clean tray or a clean surface, such as in the dining room, and then we give them this piece of paper which they put down, and then they can put their equipment on the tray. It just allows everything to be laid out clearly, and it means they don't forget anything. So it's quite a useful thing, simple as it is, but it does a useful addition to the patient pack. So our standing operating procedure, very happy to share, but it's very simple, but it just provides clear guidance to staff of the step-by-step processes and the pathways of self-administration, and allows us to have standards of what we need to be met, or what needs to be met. We obviously use a summary of product characteristics to provide a lot of information around the denosumab, and that goes into our SOP. And our SOP has been ratified at our hospital chemotherapy implementation group, so is now published on our hospital intranet page. So the pathway needs to be thought through properly. We have patient pathways and we use them every day, but we don't always write them down. But it's useful to have that step-by-step guide, and this ensures that patients don't get missed, and that important parts of the journey don't get missed. So we've mentioned about identifying the patient, and through patient identification, we then build up a caseload of patients. So we have allocated both our metastatic breast CNS and also our SACT CNS to both have a caseload of patients who are on the self-administration pathway. We have a separate page within our electronic diary. So our schedule we use Mosaic in Dorset. Our schedule has a separate page that we can put the patients on and know they won't get forgotten. We also register all our patients for subcut denosumab on our PAS system. So again, we can pull reports of which patients are on the system and how frequent they're being seen, etc. And obviously that is useful for recording, but also to ensure that we can feed that information back to CCG when it comes to things like budget planning. Pre-treatment bloods, obviously vital. We do our bloods prior to each treatment, and we do full blood count using these and calcium, liver function tests, and we often do a phosphate and a vitamin D as well, just to start with for sure. It's important to have a baseline of blood so that we can then compare moving forward. Timing of bloods is obviously quite important, and we want our bloods done within a few days of the denosumab injection to ensure that they're up to date when the injections are given and the patient's assessed. Patient assessment is key part of the pathway, and the patient assessment is done generally over the telephone or by video call. So we use something called Attend Anywhere software, and that allows us to actually obviously observe the patient and for them to see us. We are using that increasingly, but as I say, telephone is also an important part of our assessment toolkit really. And at that telephone assessment, we obviously review the bloods that have been taken recently. We check the timings of those bloods and the parameters. And we also ask about toxicities from previous treatments, including injection site reactions. We also think about the interval from the last injection and ensure that the timing is correct. And we ask about symptom assessment to ensure that patients aren't getting any new symptoms that may need to be reported back to the clinician in charge. We also, at every assessment, ask about dental health. And, despite giving patients information up front about that, it's always a useful opportunity to remind about the importance of timeliness of any dental care that needs doing, and also to report any problems such as jaw pain. Once the assessment has been done by either the CNS or in some cases the doctor, we arrange the prescription to be authorised on our electronic prescribing system. and that then will effectively authorise the self-administration. And then we liaise with our in-house pharmacy to arrange delivery of the medication to the patient. And depending on how long the patient's been on denosumab and how established they are, we will dispense between 1 and 3 vials at a time. At the time, we also dispense the supportive equipment. So the pharmacist will also, in the bag, ensure there is needles, syringes, drawing up needles, a sterette, and some gauze. And so we do that on each occasion, so the patient's got plenty of kit. I didn't mention sharps box. We also do ensure that patients have a small sharps bin that's sent out with their first round of injections. And then we obviously contact the patient, and once the drugs have been delivered, we've already given the patient authorization to self-administer once they've received the drugs. And then we document everything on our electronic records just to ensure that the loop is closed and that we know the patient has received their medication and administered their medication. And it's very important to ensure that the treatments are closed within the electronic prescribing system, because obviously it will affect our SACT upload and we need to ensure the data is accurate. So I'm not going to talk too much about dispensing and delivery, because Andy will talk a bit more about that in detail, and when he talks about oral chemotherapy, and of course delivery is very similar. But as I mentioned, we will normally deliver 1 dose, and we will do an assessment for each month. And when the patient becomes established, normally between 3 and 6 months, we will then consider giving the patients more injections, more supply of injections. Our prescriptions are initiated initially by a consultant oncologist and then approved on a monthly basis by either the oncologist, hematologist, or non-medical prescriber. Obviously, it's important that we inform pharmacy, so communication is key, and we communicate either via telephone or within email to ensure there's a trail, really, to ensure that things don't get forgotten. Screening of the prescription is obviously key. Our oncology pharmacists are a very important part of the process of ensuring that the bloods are checked again, and against any local guidance and national guidance. We identify suitable delivery dates and confirm those with the patients, and we can ensure cold chain as necessary. And I've mentioned before, we supply medication needles, syringes, etc., in sharps boxes, and we can supply more of those things as and when required. As you say, health and safety and clinical governance issues are important to consider, and it's really vital that we follow our standing operating procedure, and as part of that, we must ensure that a robust assessment is conducted at each cycle and is recorded within the patient's record. We consider patients' safe handling of medication. Who else is at home? Is this patient and their environment suitable for home administration? And that's quite important to consider. And thinking about other children or other vulnerable people that might be in the home, and just think about the setup at home, and is this a suitable environment for patients? Also thinking about storage facilities. If we're going to be administering or delivering more than 1 vial at a time, have they got suitable storage for those other vials? And thinking about things like health and safety and wastage, thinking about needles, syringes, and other equipment that will need safe disposal. Record keeping I've mentioned, and it's important, as I've mentioned, that we close the loop and ensure that our electronic prescribing records are up to date and have fully completed, so that we can keep our SACT data accurate. And obviously all our assessments and communication with patients is all recorded within the patient record. Informed consent is obviously really important, and it's important to ensure that we check consent at every opportunity. So every time we assess the patients, we ensure that they understand the objective of treatment and that they're happy to continue with self-administration. Standing operating procedure is reviewed on a regular basis as per trust guidelines. Assessment is obviously important, as I've mentioned, but it's also important to be timely. So we would always ensure that we assess the patients and bloods are done, we assess the patients and authorise administration all within 1 week. CNS review is important, and that obviously goes hand in hand with the other assessments. And even where patients are being, their care is being primarily led by a CNS, be it the SACT CNS or the metastatic breast cancer nurse, we still obviously arrange regular oncologist review every 3 to 4 months to ensure that the patient's scans are reviewed and any other actions that are required are actioned. And safety netting, I've mentioned, important that patients don't feel isolated, that they feel they've always got somewhere where they can go if they've got problems, whether it be with the actual injection, the logistics, delivery issues, or whether it's about side effects or anything else regarding their disease management. So we ensure patients all have their hotline number and also their relevant site-specific CNS numbers to contact us on. And that draws us to the end of my sessions. I'm now going to hand over to Andy, who's going to talk about the home delivery of oral SACT chemotherapy, the oral SACT, and also supported medication.
Okay, so just to give you a little bit of background, so I run our subsidiary pharmacy. I know different hospitals have got different setups, but I'm sure you've come across that there are outpatient pharmacies springing up in most hospitals up and down the country now, either operated by a commercial company like Boots or Lloyd's, or by an in-house company. So we've gone down the in-house road. So we've opened a separate pharmacy as a limited company. It's wholly owned by the hospital trust, and all directors are trust employees, but we function as a separate legal entity. Our contract at the moment is just to dispense for Dorset County Hospital's haematology and oncology patients, and we're located at the entrance to the outpatient chemotherapy unit. Benefits of us being there include VAT savings on medicines being dispensed with the intention of being taken in the patient's home, by having a specialist proper trained pharmacist always on site for screening cancer patients, and cancer patients being able to then come and ask questions about their treatment of the pharmacist. By separating the workload of cancer outpatient workload out from the rest of the hospital dispensing also means that we get quicker turnaround of those prescriptions and patients aren't waiting as long for their medicines. And all of this also has led to improved patient safety. So with COVID coming along, we were challenged with how do we try and reduce visits to our patients who are on oral cancer therapy coming into hospital, and at a time as well when all the commercial home care companies were also saying that they weren't able to take on additional caseload. I present here a map of Dorset just to give you an idea of our location and the area that we serve. So we're the blue dot in the middle. We already the main hospital pharmacy have the contract for dispensing for all of the community hospitals and mental health units in the region, which are all marked blue on this map, and we do have a fleet of delivery drivers who take medicines to these units twice daily. So we set our delivery service up using the existing delivery drivers team. We basically took on an extra driver into that team along with an extra vehicle, so that they could then have the capacity to put out, in addition to doing the routes out to hospitals, also then do a route each day going out to patients' homes. We've got one dedicated driver each day going out doing those home deliveries. Given the geography in the large area, we have had to divide it up sort of by postcode area. So we can't guarantee a particular delivery day. We can't deliver next day delivery. We make sure that each area of the county gets at least one delivery a week on the home delivery service. Typically set up so we sort of cover Weymouth, go south towards Weymouth and Portland one day. We go west towards Bridport, Lyme Regis and Bedminster on another day. Another day we'll go north towards Sherburn and Shaftesbury. And then another day we'll go east in towards Purbeck or towards Poole and Bournemouth. In addition to that, if we do have any emergency deliveries, we can sometimes put them on with the community hospital delivery routes, but they are under quite time pressures, so they can take on maybe doing 1 or 2 deliveries, and particularly if they're not too far off their routes, but they can't really deviate very far from their routes, because otherwise it makes them late for getting all their hospital deliveries in. So the process that we work through, basically, so the patient is identified by the clinical team, whether that be by one of the consultants or by one of the specialist nurses, as being on oral chemotherapy and suitable for a home delivery of it rather than coming into the hospital to collect. They then write the prescription, which is usually done on Mosaic, which is our electronic chemotherapy prescribing system. Some supportive medication may on occasion be prescribed on paper prescriptions, but those prescriptions are then sent to a pharmacy either electronically or on paper, and pharmacy are advised that there is a prescription that needs to be delivered. And I ask that I'm supplied with an idea of time frame of how urgently it's needed to help me with scheduling the deliveries. And the next part that's done by the pharmacy team is we then check the patient's address and identify when would be the next routine delivery route, and we put that on the delivery list. We then sort of separate things into two work streams there. There's the work stream going across the middle of the line, which is handled by the pharmacy delivery team. So I from my pharmacy send down to the transport manager in main pharmacy a list of patients who are on delivery for each day, usually a day or 2 in advance, so they can then do the route planning. I don't actually put the routes into any order. I just pick which patients are going on that route, and I let them do the logistics from that point of view. And they then all contact the patients to check that someone's going to be at home to take receipt of the delivery. Meanwhile, then from the pharmacy end, we then screen. The prescription is then pharmaceutically screened by an oncology pharmacist and then is dispensed. So it's all prepared, ready for collection by a delivery driver. So each morning we have one delivery driver come up from the main pharmacy, clutching the list of those items they're expecting to collect to deliver that day, which by then has been sorted into the delivery route order, and they then check off against the list, against all the products that I've given, all the bags that I've given, and make sure that they've got everything they're expecting, and try and resolve any queries if there are any discrepancies between the delivery list and the items before they leave. And then they then do the deliveries to the patient's home addresses. At each home address, they check patient details against the delivery log, make sure that they are handing it to the correct person or someone who that person has authorised to take delivery on their behalf. And delivery is done in a COVID secure manner. And they've got a standard operating procedure that they follow. So they take a basket with them. So all the items are sort of placed in a basket outside the front door. The delivery driver then steps back from that, lets the patient come or their representative collect from the basket, and then once they've gone back inside, retrieve their basket and then wash everything down. So part of this, of course, it involves also the medical and nursing assessments, which I'll hand over back to Abby quickly to go through.
So obviously, as with the denosumab, medical and nurse assessment of patients on oral SACT is vital. It's really important, and you'll all remember the alert in 2008, which is a long time ago now, but really reiterated the importance of assessment, particularly for oral patients who sometimes can perhaps get slightly less assessment than patients on IV SACT. So the patient is reviewed prior to every cycle, and that's generally via video or telephone consultation. And as I've mentioned, we use Attend Anywhere, which is the software of choice for Dorset. The doctor or the nurse or nurse prescriber, AMP, all the prescribing pharmacists will review patients on oral SACT. So we have a number of clinicians involved in patients' care, depending on the disease site and the treatment treatment they're receiving. So as part of our assessment, obviously we assess toxicities using nationally or internationally recognised toxicity assessment tools, and we record those toxicities within our electronic prescribing system. We also assess symptoms of disease and obviously would highlight any concerning features to the clinician in charge of patient's care, and that may or may not mean the patient receives the SACT, or sometimes they don't. We would obviously, as part of that assessment, review any imaging and investigations, including bloods, but also sometimes CT scans and X-rays to ensure that there is ongoing response in a positive way to treatment. We then at that point would approve the SACT prescription within the electronic prescribing system, and we at that point would, when we finish the consultation, would obviously make subsequent appointment for the next cycle of treatment to ensure that patients don't slip through the net. We will, at the same point we make the next outpatient appointment, we also then will send subsequent blood forms on to patients to post alongside their outpatient letter. On some occasions where some hospitals may of course not use paper copies for letters and things may be done electronically, but it's important that patients have adequate supplies of blood test forms that they can use to get their blood tests either in the hospital or in the community, depending on what services are offered locally. We always send a copy of communication to the GP so they can be kept up to speed with what's going on in terms of patient's treatment. And the last point, and the most important point probably, is that we always email or telephone the Fortuneswell pharmacy to ensure that timely delivery is arranged of those oral SACT treatments. And lastly, we remind the patient about the 24/7 emergency contact number, and we try and do that, by as many staff as possible, be it pharmacy, nursing, or doctor's assessment. So important that patients who are on oral SACT and are having home delivery don't miss out on the important sort of nursing input that these patients would have received when they came to the chemotherapy unit previously. So it's just important to make sure that we cover the core fundamental things that need to be covered, and patients are feeling fully supported with their treatment. So I'm going to pass back to Andy now, who's going to talk about screening.
So prior to dispensing, all prescriptions need to be screened by a BOPA trained pharmacist to ensure that they are safe patient prescriptions for that patient. The things that we check against include previous prescriptions and look for any unusual dose changes. Also comparing the prescription against standard regimen for that particular SACT. Also looking at their blood results, and we rely quite a lot more heavily on medical notes when we haven't got the patient in front of us. And then we have got the ability, and I do quite routinely speak to either the prescriber or the patient's site-specific clinical nurse specialist, or sometimes phone the patient as well to find out what's going on and make sure that any potential queries that have come up have been resolved, and we know exactly that it is a safe and appropriate prescription, or take action to intervene if it's not, to make those changes. But it is a challenge sometimes not having the patient there in front of you, because that's often a big source of information that as a pharmacist we've lost by doing home delivery, and I'm sort of sat in a cupboard, not able to see the patient, and I'm just looking at, I've just got their medical notes and a prescription in front of me. So this is just a reminder again of that process that we followed, that I've already talked us through. So I've included here as well a copy of the delivery list that we put together for our delivery drivers. So we record the name of the patient. A contact telephone number is very useful to a delivery driver, particularly with some of our remote villages where houses only have numbers and don't have names, or some of our patients are quite hard of hearing and don't always hear someone knocking on the door. So it's quite handy that the driver has got the phone number there and the ability to phone the patient and sort of say, where are you? I'm having trouble finding your address, or I'm knocking on your door but no one's coming. And then the full delivery address, particularly important, the postcode, to help them with route planning processes and being able to put it into their sat nav to find the addresses. And then recording as well other useful information for the driver, like are there fridge items that need to be provided as well as ambient items? Is there a controlled drug within the delivery that they need to make sure is handed over to the appropriate person? Or indeed, if they don't fail delivery, that needs to make sure it comes straight back to pharmacy and back into a controlled drugs cupboard and be signed back in the controlled drugs register. Have we successfully, prior to a delivery, have we managed to successfully make contact with the patient? And if so, is there any information that they have provided to us, like I'm only going to be in at a certain time, or if I'm not there, you can leave it with this neighbour, and I authorise them to take delivery on my behalf, or sometimes they give us useful information about helping locate the house if it's difficult to find, or we've got quite a few of our patients who live on farms, and it's, I might be out in the yard doing something, so these are the places to sort of look and find me. Because if there's no answer from the door, it's I'm out in the cow shed, or so we've got so it just helps the drivers then in locating the patient more quickly. And then there's a section for the delivery driver to record what time they delivered and who to, just in case any queries come up at the end. So the benefits of doing the home delivery service include it reduces the patient's visits to the hospital, and that largely improves their experience. It means that they haven't got to take time out to come to a hospital to collect their medicines. They're not paying out for fuel costs. They're not paying out for parking when they come to the hospital. And it's supporting them with shielding. It's also supporting the virtual clinics, because it, to my mind, almost defeats the object of having a virtual clinic, or phoning the patient or doing a video conference with the patient in order to keep them out of hospital in terms of having a clinical appointment, and then but you've then now got to come into the hospital to get your medicine. So it's supporting that as well, and the infection control associated with COVID around that. It also helps a little bit with our stock management, because we've now got a bit of a lag between when the patient has their appointment and review and decisions on continuing treatment and supply of the medicines, rather than coming straight from the face-to-face appointment straight to collect their medicines. So you've got to make sure you've got them in preemptively. We can always, those patients who we're thinking they may stop, they may have a dose change, I'm now not pressured into ordering before their appointment. I can wait and see what the clinic outcome is before I'm ordering, and I'm less likely to get stock sitting on the shelf that I've ordered in for a patient who's not going to have it because of a change in the treatment. We also save some of the capacity in the chemo unit, because we haven't got patients coming in and taking up a chair whilst they're waiting to be assessed for having their oral treatment. We've talked about some of the cost savings around VAT as well, and being able to reclaim VAT on prescriptions being dispensed through the outpatient subsidiary company. And there's also the benefit that when refrigerated items are going out to patients, we're maintaining the cold chain. Whereas a lot of the time, we've got one or two patients who, when they're collecting fridge items, do bring in cool boxes and things to take them home in. Particularly one or two of our patients who are on romiplastin injections are very good at bringing in a cool box with them when they come to collect their medicines. But the vast majority of fridge items will be unrefrigerated when the patient takes them home, whereas when they go out with our delivery service, they are in a validated cooler throughout the journey. There are some challenges as well associated associated with the home delivery service. We lose that face-to-face patient contact between pharmacy and the patient. In particular, there are occasions when patients have come in and collected medicines, and I thought, you sort of eyeball them and you think, do they look well enough to carry on with this treatment or not? Do I think I need to get them assessed? Do I either need to sort of try and assess them myself, or do I need to get one of the specialist nurses or one of the doctors to come and assess the patient? And sometimes you pick up on those visual clues sometimes when they come in and think, well, you're not as well as you've made out to the doctor you are, and you lose that when you're delivering things out and you're potentially speaking to them on the phone, but you're not actually seeing them face to face. Another challenge is, particularly now that more and more of our patients and coming out of shielding, is that we do sometimes come into conflict with the limited delivery opportunities. And we're really sort of restricted to, we've only got one driver, we've got a large geographic area. We can't give them a flexible delivery. We've got to sort of say, right, this is the day we're doing your route this week. I don't know what time it's going to be within there, because it depends upon how many patients are on the list. And that sometimes can cause conflict with patients, because it might not always necessarily be a suitable day, particularly if some of them are starting to return to work, or that they don't always necessarily like sitting in all day waiting for delivery, not knowing what time it's coming. But conversely, we like to try and keep that flexibility of being able to add a last minute one in if we can, and if we've given everyone fixed times along the route, we then can't amend that route and add another delivery in sort of the day before. Communication is definitely important and a key challenge, making sure that pharmacy are aware of all of the prescriptions that need to go out, and then also making sure that patients are aware of the expectations of when things are coming, making sure that they're aware of what timescales we can work to. We've tried to make it as clear as we could when we set it up. We can't do a guaranteed next day delivery service, and same day delivery is completely impossible for us. And like I said, it's a benefit with the patient experience. Some of these things are challenges for the patient experience as well, and it's not like ordering your Tesco's delivery where you get a 1 hour window, but that's something that maybe we can improve in the future. So just to round off, a little bit of feedback that's come in from patients around the service. So these are all real patient comments. One has said, it saves me money on a 26-mile round trip coming to the hospital to collect medicines. There's another who said, I feel a lot safer because during the COVID pandemic, I haven't had to come into the hospital to collect medicines. There's another patient who regularly emails us and tells us what they need, and it's been delivered within a few days. We get everything ready. There's another patient who said, well, actually, I've asked the delivery driver if he can ring me when he's nearly to me, so that I don't have to stay in all day waiting for delivery. He'll give me a ring when he's half an hour away, and that has helped me still manage to go about everything else that I need to do that day. So we'll now open the floor up to questions.
Hello, thank you, that was brilliant. We've got quite a few questions, so I'll just try and move through them as quickly as we can. The first question is, how do you monitor your monthly bloods when patients are being assessed over the phone?
So how do we monitor our bloods? Well, our bloods obviously come up on our electronic PAS system, so they're all available. So we use there are 3 patients can obviously live anywhere around the county, but the majority of our bloods will come straight through to the hospital pathology system. So we look them up electronically and talk to the patient. Luckily, we've also got access to the east of the county, as well, and we can look up bloods if patients do live on the peripheries of East and West, and we can look up bloods there. So that's fairly easy to manage.
And I've also got access to bloods from they go through Yeovil Hospital lab as well.
Yeah.
So it covers most of the county, and we do anything that needs blood results before the drugs are dispensed, that they are checked, and I will phone patients up and say, I've been asked to send you your medicines, but I haven't got your blood results yet. When either did you have, or are you going to have your blood tests, and where, so that I can then find out where to look for them, and when blood results are going to be coming in, to make sure the bloods do get checked before they go.
All right, brilliant, thank you. So next question is, have you thought of toxicity assessment clinic to address the issue? How do patients receive denosumab? Is it part of home delivery, or do they collect from the GP?
So we don't do it via the GP in Dorset, so we do it all still through the hospital. I suppose we do have a toxicity assessment clinic in the sense that the monthly review is where the patients are assessed using toxicity criteria, and then that information is uploaded onto their electronic record. So the pharmacist can see that as well. So rather than bringing in another nurse assessment, generally it's a non-medical prescriber assessment. So myself or the breast cancer nurse or the SACT CNS will review those patients in their own right, so that they won't need nurse and doctor review.
Okay, that's great, thank you. The next question is, how have you managed the financial loss from patients not attending in terms of tariff? This loss of income has put a stop to us, as the VAT savings are not directly cost savings to the directorate.
Well, I'd say that we're on a flat cash basis at the moment anyway. So certainly for the moment we hasn't impacted our tariff. But certainly the VAT savings, there is they are split in terms of the savings between us and our CCG. Is that correct?
Yeah. Those gain share, depending upon whether it comes from, whether it's in tariff, whether it's CCG funded, or whether it's NHS England funded, but there are gain share arrangements in place with all the funds of the VAT.
Okay, brilliant. The next question is, someone's just asked the name of your scheduling system again, please.
We use Mosaic. So a Mosaic, which is chemotherapy prescribing, and also incorporates radiotherapy, and the scheduling is part of our electronic prescribing system.
Okay, that's great. There's another question about Mosaic, which is, do you sign off the medication on Mosaic as treated as well, or do you do it another way?
So
anything that goes out on home delivery gets signed off as treated elsewhere.
Okay, brilliant. That's an easy one. How have you managed the problems with getting patients to be reviewed by dentists since COVID?
That's a good question. Very good question. I saw a patient in clinic this morning, and he, is due to start bisphosphonates. We said to him, you can't start them until you've had your dental screen done. So I think, we can ask patients ourselves around their own dentition, and if they are confident that they have no problems at all with teeth, then we will do that part of the consent process, and we will allow the patients to start. But if they've got any concerns about their dental health, then we ask them to arrange a dental screen. And so far we haven't had problems. I think we emphasise patients that they need to tell the dentist that they are a chemotherapy patient, they're a high risk patient, and they need to start this treatment. But I think if there was any doubt around dentition, we would delay starting the bisphosphonates.
Okay, wonderful. Someone has said, we've been drawing up our denosumab with closed systems. Have you or others introduced this?
Yes, so we've done the same, and interestingly, the Amgen data, the educational data, doesn't look at closed systems, but we are using closed systems too. So we will supply the patient with a vial adapter, so that we don't need to use needles. Yeah.
Okay, great. Someone's asked, are the 3-monthly oncology reviews face-to-face clinics?
Not necessarily. We are now, well, I say now, you know, in the south at the moment, we're still trying to actively discourage patients from attending hospital. However, you know, there is great value in seeing a patient, and we are certainly not saying you can't come, but we are trying to encourage clinicians to use the Attend Anywhere, the video conferencing, but some of the clinicians are a little bit resistant to that, as are some of the patients, particularly perhaps some of the older patients who perhaps, it's a bit of a generalization, but some people just don't like the thought of doing it. So we will still have some face-to-face, but it is not necessarily each time the 3 monthly, no.
Okay, great. So the next question is, I would assume that these patients are only receiving treatment with denosumab, or how are other agents administered, such as, excuse my pronunciation of this, I'll give it a good go, palbociclib and fulvestrant for breast cancer patients?
Yeah, so the metastatic breast cancer nurse is certainly going out and doing the things like the fulvestrant injections. The palbociclib is an oral therapy, and again, that would be delivered as part of the home delivery service. But obviously, if patients are coming in for other intravenous SACT, they would have their denosumab when they came in as part of that treatment. So this is really for patients who are on oral therapies who are just on supportive bisphosphonates.
CNSs, also the community oncology nurses are also doing some of the fulvestrant. So we're delivering it to the patient's house, and then the nurse is going in the next day to administer the fulvestrant.
Okay, great, thank you. Do patients get a delivery window in terms of the time of day? And have you had issues with many failed deliveries?
We sort of what I tend to do in terms of delivery windows is, if someone says that there's a particular time of the day they can't be in, then I'll let the delivery driver's manager know that when he schedules the delivery route, to try and accommodate those requests. But we sort of can't ask everyone, do you want morning or afternoon? Because you know, and inevitably get two people in the same village, one wants morning, one wants afternoon, and then it doesn't work. So it's really sort of, once I know I've got someone who maybe has got a specific requirement for morning or afternoon, and anyone who's nearby in that area, then I will sort of tell them we're trying to do afternoon to accommodate someone else or whatever. But yeah, it's a difficult one when you're dealing with sort of some of the delivery routes. It can work out at sort of 150 route miles, mostly on single track country lanes, which is a challenge if you're going to ask them to keep backtracking on themselves.
Absolutely. So we've got a few more questions left. I know that we are now at 4 o'clock, but I'm going to try and get a few more answered before we log off, if that's okay with everyone. So the next question is, do you deliver IV SACT at home? If so, do you have similar challenges?
We don't at the moment, no, that's our next step. We are
I'm really sorry, I'm really struggling to hear you.
Wait, one second. So is that better? So we are, can you hear me?
Yeah, that's better.
Okay, so no, we don't do intravenous delivery at home at the moment, but we are just in the process of trying to finalise a business plan to do our next steps, which would be delivery of certain drugs at home. So it's something that we want to do, but we're not doing yet.
Okay, wonderful. So the next question is, how many patients on Oral SACT are assessed each month?
I would say, as for how many are assessed, I don't know. But I should, yeah, like I say, some of the haematologists don't necessarily, and they've got patients from, some of the haematologists sort of with CML patients who have been on the same treatment for years and years and years, that they sometimes only do every 2 or every 3 months. But I've got roughly, I think it's about 230 patients that we're doing home delivery of SACT to. but those delivery, those vary between sort of 3 weeks. Some are 3 weekly, some are 4 weekly, and so some of the haematology ones are sort of 8 or 12 weekly.
Okay, brilliant, thank you. Do you provide a full review for every cycle?
So yes, so we do unless patients are fully established. So for example, with the denosumab, when patients become well established on treatment, and it's definitely down to clinicians' discretion, we will sometimes go to less frequent review. But it's important not just to review about toxicities, it's also about supporting the patient with other aspects. So it's a holistic assessment. So yeah, we would review all patients each cycle, whether that be nurse or doctor.
Okay, that's great. So the next question is, do you have plans to expand self-administration and delivery of other subcut treatments?
So yeah, we've certainly considered other things. I mean, there are other things that we could consider, such as trastuzumab, rituximab, bortezomib. So we just need to think around the safety. Denosumab is, although there are safety issues, it's an easy one to start with, and we need to think about the logistics and about the other safety aspects of some of the cytotoxics. So I think it's something we could consider in the future moving forward. We've certainly done it in the past with things like subcut cytarabine, where we've had patients that find the daily grind to hospital too much, and we've already dipped our toe in the water with that. We don't tend to use so much subcut cytarabine now, but when we have done it in the past, it's worked well. So I think that we've tested the theory.
Okay, that's wonderful. That is all that we've got time for today, but I think we've managed to answer quite a few questions. So thank you both very much. That was really, really interesting, and I hope that you all enjoyed it as well.